Good afternoon, everyone. The Department of Surgery and Orthopedic Medicine report. Today, the last week in this breast cancer awareness, I would like to present Dr. Binti Kokelea, our resident, our general surgery resident, who will talk about the phase of breast cancer in the Gambia. So, Binti,
thank you very much. Good afternoon, and thanks for coming to the presentation. So this is a continuation of series that have started 2 weeks ago about breast awareness. The first one was talking about the clinical approach to breast cancer. The second one talked about the histopathology approach in breast cancer. And I will be talking about the face of breast cancer in the Gambia, particularly in Edward Small Teaching Hospital. So this is the plan. We're going to start with a small introduction, and then we talk about the breast cancer incidence at EFSTH. Talk about the breast cancer patients, their details, the number of mastectomies, the number of chemotherapies, and the mortality rates. So the Gambia is the smallest country in West Africa. It has an area of 1,300 kilometers square, and its population is estimated to 2.9 million. The female portion of the population is estimated to 1.1 million, so more than half of the population. So why are we having this month dedicated to breast cancer? It's because it is the second most common cancer after the cervical cancer. in female, according to the Gambian National Cancer Registry, who was operating from 1998 to 2006, where it resumed because of lack of fundings, according to Professor Ogun, who presented last week. So you can see that there's need for data collection because the cancer registry is not operating anymore. In this regard, Dr. Mohamed Gay made a retrospective study from 2012 to 2020. He collected the cases and ended up with 98 cases of breast cancer. That was given a prevalence of 4.13, but only at EFSTH. So the breast itself is embryologically a modification of a sweat gland. So it goes through structural changes throughout the life of a female. And especially during sensitive periods like menstruation, periods, lactation, pregnancy, and after menopause, we have a lot of structural changes and pathologies that occur. So in order to deal effectively with this pathology, at EFSTH, we have a breast clinic that is running throughout every week. So every week, there's 4 clinics patronized by 1 consultant. The average patients seen each day at each clinic range between 12 to 18 patients, giving an average rate of 56 patients seen weekly, 224 monthly, and 2,688 yearly. So this is a picture of our outpatient clinic, which has 4 clinical rooms where patients are received. It needs a little bit of improvement, but we thank all the staff and our HOD for trying hard to improve the state here, because we know that a clinic should have at least some images, some videos to educate the patients that are coming about the pathology before they can see the doctors. So when it comes now to patients that we see at the clinic, we know that the breast has structural changes that are subject to cyclical changes in general. So the pathology that we see ranges from normal gland differentiation, from pre-malignant differentiation like Paget disease, and for definitely malignant changes. So we can see here that more than 50% of our patients are less than 30 years. So this can be due to the fact that at this age, we have lots of cyclical and hormonal changes in the structure of the breast, giving to pathology like fibroadenomas, cyclical mastalgia, galactocell, and more. And you see here the lesser portion. Over 50 years, we have usually ductal and lobular changes due to the involution of the breast, like duct ectasia and more others. Sorry, I'm trying very hard for my English, but I hope you can understand. So, coming to the cases that we see, among the year 2020 to 2022, we have recorded 79 cases. So this gives a prevalence of 38.9%. This is a very high number. This means that among 100 women who will come to the breast clinic with breast complaint, 38.9, almost 40, will be positive for breast cancer. So it's a very high number. Coming to the average range, you can see that normally in the Western country, they say that breast cancer screening is started among like mammography, women aged 40 and above, because it's usually prevalent among these ages. But here in our setting, you can see 25% of our patients with positive breast cancer findings were under 30 years. And the youngest one being 18 years. And you can see here, 30 to 50 years old account for 47%. So here, cancer screening should start at very early ages compared to the figures that we have from the Western countries. Coming to the tracks, the Mandinkas were the one that scored the highest points, 38%. I believe because they are also the highest among the population in general, among the tribes. So after them came the Fulas, the Wolof, the Jolas, and the lowest percentage were about among the Serep. Now, this slide is very important because most of the patients that we receive here come at an advanced stage, from local medication to traditional healers. They will come only when the stage is completely advanced, as this figure is showing here, 43%. Present to the clinic 6 months, 1 year, 2 years after the first symptoms. That's why cancer awareness is very, very important still. And you see here, 9% only will present in the first 4 weeks of the first symptom. Coming to the marital status, both married and single women have developed breast cancer among what we studied. But you see, the married women accounted for 38%. So this emphasizes also the role of our husbands, our fathers, in the fight against breast cancer. Men are also there to raise the alarm and to accompany the women in the process of consultation and treatment. Okay.
Use the arrow key to walk now.
Sorry? Sorry? Among the widows. Widow?
Yes. But no, divorcee is talking about.
The divorced.
The divorce, yes.
I'm not sure about that. They should have more prevalence because we know that pregnancy is a protective factor against breast cancer.
I think it's more control. It's the figures. I think it's the figures that we look at it. I mean, the number of divorcees technically will not be as much as you would have to the married population there. Because otherwise, you are sitting there and say that, well, divorce seems to be good for preventing breast cancer, and that would be a
So this figure here shows the occupation of the patient that we recorded. You can see that the highest score, 6%, is among the vendors, the businesswomen, who usually are too busy to come and consult or are bounded by the burden of having to stop, not having any incomes when they stop working and come to the clinic. So they rather apply some local medication and continue their work in order to not be financially in difficulty. And then we have also housewives who score 70%, office workers 21%, and we have students 11%. That shows also that breast cancer in our settling start at a very early age. Coming to the educational level, you see the not educated and the one who barely attend primary school account to like the highest score here. So this emphasizes also that we have to educate the communities, especially in the urban areas, about the necessity to come and consult whenever there's a change in the breast. You can see on this slide, only 17% of our patients presented with family of breast cancer, family history of breast cancer, and 83% didn't have a family history of breast cancer. We recall from Dr. Jaitis teaching that having a first degree family with history of breast cancer increased the risk to 50%. So now, these slides here show the difficulties that we are having in our hospital, in our country, when it comes to breast cancer management. We know that breast cancer is a multidisciplinary disease when it comes to treatment, because we have 3 stages of treatment. First is the locoregional treatment or approach. And then we have the systemic approach to the treatment. And then we have the targeted cell systemic approach to the treatment. So, Budujang, you are sleeping. No, it's just to wake everybody up a little bit. So when it comes to these 3 stages of approach, the first one, that is the locoregional, has, like Dr. Chande explained before, the option of the surgery to excise the tumor and then the lymph node if they are present, and then to do a radiotherapy in order to kill the cancer cells and the nodes around the breasts or deep in the tissues. Unfortunately, we don't have any radiotherapy units in the hospital and in the Gambia. When it comes to the second stage of management, the systemic approach, there we have the chemotherapy that is available and hormonotherapy. Unfortunately, we don't have any testing for hormone receptors here in our lab. So hormonotherapy is also out of the way for us when it comes to option in treatment. And also when it comes to chemotherapy, because of lack of drugs, we only have 1 regimen that we use for all the patients. So when it comes to the targeted cell systemic therapy, the lab is not testing for receptors of gene like HER2, the human growth receptor that is very important, because when it's found in a woman and the proper treatment is given, the chances of healing is very high, but we don't have it here. So, meaning that we only have 2 ways of treating here, is the surgery to excise the lump, and then the systemic therapy, the chemotherapy. And you can see here the number of mastectomies that we have done. In 2021, we have done an average of 12 mastectomy, and 2022, 18 mastectomies. And you see the average range here. 18% were less than 30 years, young girls who have to go through this very traumatic process. Even when they have a small tumor, less than 3 centimeters, that could be treated by an approach where the breast can be conserved, but they have to go through all mastectomy because we don't have the radiotherapy to complete the treatment. So this is the difficulty that we are having when it comes to treatment. 59% were over 30 and 40 years. Still, you can see that 30 years women is still a high percentage, and they are exposed to this difficulty, trauma of having their breast removed. This image, you can see what kind of patient we receive here. Advanced stage breast cancer, where we have to do a toilet mastectomy. This is an image of mastectomy done in our hospital here for a very young patient. When it comes to chemotherapy, like I said, we only have 1 regimen that we usually use because of the availability of the drugs, is the CAP, where we have a 5-fluorouracil, doxorubicin, and cyclophosphamide. And you can see here from 2021 to 2022, we had 45 patients going through chemotherapy. And usually here we give neoadjuvant, and after mastectomy, we give the adjuvant chemotherapy. So you can see the figures. 13% were less than 30 years. So very young patients here come and have to go through this difficult process of receiving chemotherapy and mastectomies. We have an image here that shows a patient receiving chemotherapy in a chair. This is the reality in our hospital. Because these patients come to the female surgical unit that is usually filled with surgical patients and has only 8 bed capacity. So they have to receive these heavy drugs sitting on a chair. This emphasizes the need for us to have an oncology unit in the hospital where they can be followed up and managed effectively. When it comes to the mortality, it's very challenging because our system of recording is very poor. So for the year 2021, only 3 cases were recorded. For the year 2022, only 2 cases. The mortality book of female surgical where this patient arrived has been lost for the year end of 2021 to 2022. And the records office didn't have any data, so it's very challenging. Apart from that, we have put a picture here of the challenges of not being digital in our hospital. In order to have good data record, we need to go digital. We have a record book at the theater. You can see the image here, the page are tiers, and we lose the data like this. The mortality book that usually get lost, and our records office full of paper that usually get flooded, and you cannot get anything from it. So it's very important for proper data collection in order to have the proper resource, even the support from the government, to go digital, to have an oncology unit, at least where all these cases will be there and no data will be lost. So in conclusion, breast cancer is a curable disease when diagnosed early. Cancer awareness needs to be made, especially in rural areas. Everybody needs to play a role at this level in order to reduce the mortality. The Ministry of Health needs to provide effective resources for proper data collection and management of breast cancer in our country. Thank you.
So, Dr. Binti, thank you. You did a very good presentation. Was very good indeed. So, any comments, questions about the presentation that Dr. Binti did? So, medical student, any question? You understand about the factor, our challenge about the regular studies about breast cancer? How this is clear.
That's why I show an image of our outpatient clinic. And I say that usually in other countries, we see it is a breast clinic, they are in they are video, but they are coming maybe from this cover and they are learning already about the breast tissue, what is happening, family discovery, and then the treatment. They are already stimulated. But we are, I think we are all responsible. Not only somebody can make a donation and say, okay, I will make some pamphlet and put it there. Or I will donate a TV for some images. Or every time there's a question, I'm asking my I will try to educate like women in the family before they go into the clinic about this. Everybody is waiting for everybody. Ministry and all this. No. It starts at the local level, I believe. Even myself, I was a but I didn't take that effort. So we are all to blame about this.
Yes, so we I think you have to and like usually working that and the baby I remember there was someone who told me that he went about had to well came in and then the doctor and very last and couple weeks and then just totally got and it's good psychology you say right you never know that's something but that's something so I think there's a lot that we see on you constantly and doing good and something that has to be meaning that and I think he is also about the community and make sure that he knows but I think that some even almost but at least some informal way the diagnosis on the other thing would be sort of what decision it would be. How do you recognize that you have cancer? How do you tell them that you have cancer? That's also and explain the rationale behind cancer. So all these are things that we need to have a way of teaching those who are technical how to break that news, how to discuss the prognosis of somebody who has such a but people tell patients that okay, you have maybe that's too hard to do that just going to be that specific benefit and how can like what the problem that you find so I think there's a lot that you can do and the best way to do that is having a centralized cancer unit and that's something that the department has been thinking of. I think I've mentioned this on different occasions that actually engage participants, we've identified the patient of cancer, we've identified a nurse, not the cancer and that, and hopefully we're also looking at ways of making sure that it's working. Realize that there's a possibility but it's a concern and it has to be done so that patient experience streamlined. You go to the doctor, they do surgery, you go to the surgery, chemo, follow up, folders are incomplete, you have to go to the yes. I think we also need to make somebody who's learning traumatized by the give to them care and that.
Figures about prevalence of breast cancer in West Africa. I didn't take the numbers exactly because I was focusing more on Gambia. But definitely there are some figures about prevalence.
Yes, what I think about breast cancer now, I can talk about Gambia, or generally about West Africa. I remember here around 2017 when I arrived here talking about the patient with breast cancer. I think the country is working on it. So we have every month, every year, we have more patients because our patients are getting more culture about what is breast cancer. So I remember 4 years, 5 years back, we don't have a first line of chemotherapy. You know, by that time, 2017, by 2018, was difficult to get this first line. So after that, I think we are making better now because we are more stronger. We got Dr. Yaite, we make that the unit to treat breast cancer. I think we get this first line of chemotherapy. We are controlling better our patient with breast cancer and the clinic. So I hope we are working on it. I hope we will do better in the year that are coming. But I think we improve our outcome if we compare with 3 to 4 years back. Definitely, I think breast cancer is now one of our chance, and we will work on it together.
That's it. But, I think in general, it's even what's the main country because that will be occupied by another department, and we are still blessing that it's the big issue. But normally chemotherapy is given on there. The time it's not a bad. It's only taken to probably 2 weeks. But the chair always promotes that we're finding that hopefully we get I mean, those things
Medical office. President, our president, any comments, questions? Dr. Salifu?
I would agree with you, Salim, and I think this was mentioned when I presented. I mentioned that in India they did a randomized control study, and they realized that the best way in low and middle income countries to catch breast cancer, I would say prevent, because you really can't prevent breast cancer, but you can at least detect that is to have trained personnel, and that is not necessarily what the nurse. So like you're saying, there has to be some sort of outreach, some sort of instances where somebody goes in, perhaps some nurses, and then they're on that 8, 9 months, they come with no conversation. So I completely agree with you, and I think that's really the way when it comes to fighting and reducing the number of cases. That's something that has to come from us to go out and make sure that that's and I think that's similar to circumstances. I don't know what you do. So I think other guys can do that, and I think maybe we can also have a similar approach and then do our own. I think in your as we see prevention, treat it back to the max. The answer is that we need to go out and make sure that we keep our
From the cases we recorded, most of the patients come at advanced stages. Now, it's dependent on the age. So in the elderly one, the mass is usually not so big as in the younger one. So the younger one usually have a big mass, more than 5 centimeters, usually sometimes attached with local regional nodes. So the figure is more dramatic in younger ones than elderly.
I think we are going to the same point about population. We need to create culture of our places because we are requesting most of our patients according to our spending and the unit. Most of our patients that we are receiving have breast cancer stage 3, B, or C. So that means that the patient that have been going treating locally or going to traditional treatment or perhaps get some delay to go to the sleep. And most of our patients can stage 3B, 3C, even stage 4. So
Another question, because it wasn't there. I think it wasn't captured in the presentation, like let's say clinical features or let's say clinical presentation, right? Whether it comes presenting as a clinical relation, like a mass, getting an ulcer or something. Yeah. I think that's something that could also be looked at in all the literature that all the folders that you have. Yeah, probably something that's good. Because
I think that's something that we have to make. I think the small issue was have advantages and disadvantages of certain things. When the EMR started this year, all the forms were just like, so the data collection was kind of disrupted because everything was supposed to be on yeah. But the hope is we will be able to have a digital form of that form. So once we have that, then data extraction will be easy. And then all this questions that we're asking, we should be able to actually.
That's why today was the question for the sign that we're talking about. What we need to get in the country is research. To get more information about the patient. And the only way is to, to go to the computer, get all information. And we will know what. And the screen. I remember the presentation of the project. The screen is important for all the time. The fans have to understand.
When you say family size, you basically mean number of children. Number of children somebody has. Okay.
And besides, mostly family, and maybe I will start that.
Understand your question very well. But when it comes to moving,
This part,
maybe
maybe I might say, but usually I think we need to talk about mostly families.
yes.
Yes. So is there any other moving I will start that we see?
Okay. Okay, this was discussed in the first presentation. I've been trying to talk about it.